Happy Doctors Day to all the doctors here. So today we're very pleased to have Dr. L. Ramakrishnan with us. So a brief intro about him. Dr. L. Ramakrishnan is a public health professional and vice president of SATI, based in Chennai. He earned his doctorate in 2000 from the University of Texas at Austin, USA, and has worked in health and human rights nonprofit settings in the US and in India. He supports various programs, including MIT Digital Health Initiative and the many LGBTQIA plus inclusion programs. He has previously led programs on mainstreaming and decentralization of HIV/AIDS services. He's also involved in internal and external capacity building in areas of monitoring and evaluation, documentation, operations research, and gender and sexuality. We are so pleased to have you, sir, with us. So if I may introduce the crowd to you, this is a very mixed group of doctors, nurses, social workers, psychologists, and a lot of other health professionals. So I hope this will be a time of mutual learning for both of us. Thank you, sir. Please take over.
Thank you very much. I will try to share a PowerPoint. Just give me 1 second. Okay, is my screen visible and am I audible?
Yes, sir, it is. You're audible.
Okay, great. So it's really good to be able to return to this course and this group of folks working in palliative care. I think this may be the third or fourth cohort that I've had the pleasure of addressing. I'm going to be speaking very briefly about gender, sexuality, and mental health, and hopefully we can spend some time discussing the implications of this for palliative care. Yeah. So I will give you an overview of concepts related to gender and sexuality, speak a little bit about the stressors and the mental health impact, reflect a little bit on the stressors from family, from society, from healthcare systems, and the legal and policy frameworks. We will try to either go over frequently asked questions that have come up in previous sessions, or just keep it open to questions from the participants. So actually, before I go, I just wanted to do a poll. If I see that there are 28 people, if any of you have had, who feel that you are fairly knowledgeable about gender and sexuality, can you just use the reactions to raise your hand like this? Yeah, so we have one. Let me see if I go to the other room. Two. Okay. How many of you? Okay, so 1, 2, 3, 4, 5. You have 3 here. How many of you feel you have like very little knowledge and very little prior exposure to gender and sexuality beyond what is, commonly understood? So in the sense, absolute newbies. So that's about 4 people raised their hand. So I'm guessing everybody else is somewhere in between. Okay, that's great. Okay, let's get back. So this gender and sexuality, there are various concepts. You would have heard the letters LGBTIQ, etc. So broadly, we can break this down into sexual orientation, gender identity and expression, and sex characteristics. So I will just go very briefly into sexual orientation, which itself is part of a broader cluster of attributes called sexuality. So sexual orientation, very briefly, is who you're attracted to. Sexual behavior is who you have sex with, and sexual identities, how you identify, as gay or heterosexual, bisexual, pansexual, etc. The point of this slide is to say that the 3 of them may overlap, but not fully. So imagine a woman who's only attracted to other women. She, given circumstances where she's supported and feels confident enough to come out, she may identify as lesbian. But in a lot of cases, especially in our cultural context, many lesbian women are actually forced to hide their orientation. And also many of them are subjected to forced marriage, even if the parents get to know about their sexual orientation, the fact that they're not attracted to they're not attracted to men, they may be forcibly married to men. So their sexual behavior is dictated by the coerced marriage, but their orientation is very different, because a relationship between two people of the same gender is not illegal, but it's not recognized by law in India. So wherever you have this discordance between orientation and behavior, or orientation, behavior, and identity, there are also likely to be conflicts. So an individual who is not capable of disclosing their orientation because they are afraid that they will be looked down upon or harassed or ridiculed may then be treated to inappropriate behavior, including inappropriate case history taking in healthcare settings. So, for example, anyone, and I'm not even talking about palliative care here, if a woman goes to a gynecologist, a routine question is, when did you get married, or are you married? And these are questions that are supposed to elicit information on her, sexual history, as well as history of giving birth to children. So the question itself comes loaded with the assumption that the person is heterosexual, is attracted to men, and is or ought to be in a marital relationship. So many of these assumptions we refer to as heteronormative assumptions. So assumptions that that heterosexuality, attraction to and relationships with people of the opposite gender is what everybody is expected to conform to. So this makes it very difficult for people in healthcare settings and elsewhere, and also in cases where they're dependent on caregivers, to disclose their orientation or identity. So imagine someone is in a palliative care context and they're very, very dependent on an external caregiver because they have already been shunned by their family and they have no biological family to call their own. They may be so, wanting to have palliative care and palliative care support, and they may dread that if they actually disclose their orientation or identity, they will be shunned and they will lose what little support they have. So there are a lot of social circumstances and sociocultural attitudes that prevent people from disclosing their orientation or identity. Okay. So we will talk about identity a little more. There are a lot of terms which can be confusing, but let's just go over them, and if there are questions, we can come to later. So gay is a common identity which corresponds to an individual who has primary or exclusive attraction to the same gender, coupled with no attraction to the other gender. Bisexual is an identity that refers to significant attraction to more than one gender. It's not that if somebody is attracted to men, they can't be attracted to women, or vice versa. That may be the case for some people, but for some people, they may have significant attraction to multiple genders, which need not be 50-50 to be classified as bisexual. Heterosexual is an identity corresponding to primary or exclusive attraction to a different gender. As we mentioned earlier, lesbian is an identity corresponding to the primary attraction of women to other women and lack of attraction to other genders. There is a term pansexual, which is similar to bisexual, but people who are pansexual typically say that they are attracted to other people regardless of their gender. A person who's not having an orientation, a sexual orientation to other people is referred to as asexual. And the term queer, which was originally a pejorative term, is a term that people use to state that they're different from the mainstream, and they may identify as, having a different sexual orientation, but not necessarily one that fits into the above categories. For example, there are people who are sexually fluid, who have attraction to one gender at some time and other genders at other time. And rather than trying to explain this concept of fluidity, they may just choose to call themselves queer to align themselves and ally themselves with the overall community. So what I've spoken about in the last 2 or 3 slides is about a person's, attraction, which we also refer to as orientation, a person's behavior, and a person's identity. And as I said, this is relevant to us as palliative caregivers because historically our culture and society only endorses one kind of sexuality, which is heterosexual identity and heterosexual behavior and heterosexual orientation. So anyone who is outside of this norm may face ignorance, hostility, even violence. And in a palliative care context, this can be even more crucial because if the person does not disclose their orientation or behavior or identity, you may not be able to give the care, appropriate care needed for them. You may assume that they actually have no romantic partner when actually they don't have a legally wedded spouse, but they may have a romantic partner of the same gender who they are, hesitant to disclose because that is again frowned upon. So there are a lot of issues here relating to sexual orientation, behavior, and identity. Before I go on, I'm going to just stop the share again and ask if there are questions so far about sexual orientation, sexual behavior, sexual identity, the sum total of which we're referring to as sexuality. What aspect of it do you not understand, or would you like to understand more? You can raise your hand and we can come back to it. We can get you to speak.
Sir,
Yeah.
I have
Yeah.
a question. So the
Yeah.
identity part,
Yeah.
is it something that they self-identify, or how does that part come in?
Okay, excellent question. So when we are talking about identity here, we are talking about self-identity. So if a person, what could be the case is if an individual is behaving or looking different, people around may impose their own identity, usually in terms of derogatory terminology. So terms like chakka, etc. in Hindi, or Ombodu in Tamil, they're all derogatory terms. They are not an individual's chosen identity. They may be imposed by other people and usually derogatory in nature. But here, what we are talking about is self-identity. And again, there with self-identity, not everybody is aware of the identity or how to describe themselves unless they live in a particular society where these terms have currency. So for example, a man who is attracted to men in a rural part of India where where English is also not a language they're comfortable with, may have never heard of the term gay and may not identify themselves as gay, but they know that their orientation is towards other men. So if you look at a lot of the terms pertaining to sexual orientation, these terms do not even exist in Indian languages. People have coined terms like samalangi, etc., or in Tamil, orupali irpalar, irupali irpalar, but these terms are not are fairly recent in origin, and a lot of people are not even aware of these local language terms. But yes, broadly, when we're talking about identity, we're talking about how people identify themselves with respect to their sexual orientation. I'm not talking here about people who identify themselves with respect to their gender, like transgender. That is the next topic. Okay, is that clear? Yeah, thanks. Anyone else? Okay, maybe I can bring up another point here. I use the term asexual, now referring to a lack of sexual attraction. How many of you have heard the term celibate or celibacy? Hands up if you've heard of the term celibacy. So I see 3 participants who raised their hand. 6 participants have raised their hand. So could one of you say what is celibacy? Mr. George, not you, somebody else. Abhijit, what is celibacy?
Celibacy is people who choose to remain unmarried, probably because they do not have sexual desires.
Yes and no. I think the first part of it is absolutely true. It's people who choose to be not in a relationship. Okay. But your assumption that they are doing it because they do not have desires may not actually be a valid assumption. So celibacy refers to sexual behavior and asexuality refers to sexual orientation or attraction.
Oh, okay.
So you may be you might meet someone who is celibate for religious reasons or spiritual reasons. They may be a nun or they may be a priest in a particular faith where their religion dictates that they not engage sexually with anyone. But that doesn't mean they do not have a sexual orientation. It does not mean that they're asexual. They may be heterosexual, they may be homosexual, whatever. They could even be bisexual, pansexual, asexual. But what we have is their behavior. And based on the behavior, you cannot conclude what their orientation is. Right? So that's the difference. Any other questions regarding this before we go forward? Hands up, if I'll just speak. If anybody has a question. Yeah, Sajjan George, do you have another question? Okay. So
Mr. Ramakrishnan, I just sent you a small question in the chat box. Could you just
let me just check.
elaborate?
1 second. Okay. So this was about elaborating on pansexual and what about transsexuals. Okay, I'm not yet talking about transsexuals because transsexuals refer to the chapter on gender identity, which we have not got to yet. We are in the chapter on sexual orientation. So pansexual is a type of sexual orientation where an individual feels attracted to somebody else, regardless of, I mean, to put it bluntly, what's in their pants or what's in their skirt. So they may say that they are more attracted to the, the person's intellectual attributes, how well they can hold a conversation, or in general, how attractive they are, how engaging they are. And the fact that they have a certain set of genitalia is irrelevant to their attraction. So that's pansexuality. Transsexualism, I'm going to talk about later. Yeah.
Thank you.
Thank you. Yeah, sure. Now I'm going to go back. So all of these terms, gay, bi, hetero, lesbian, pansexual, asexual, and queer, refer to sexual orientation, which is one dimension of sexuality, the other two dimensions being behavior and identities. Now we get to gender. And there are medical and psychological definitions of gender. And I'm introducing a new concept here called gender identity also. So actually, before we go to gender, I think you all may be aware of the term sex or biological sex, which is basically a term that refers to the body parts that the person is born with. Based on those body parts, a World Health Organization says that gender is socially constructed roles, behaviors, activities, and attributes that a given society considers appropriate for men and appropriate for women. So being physically active, engaging in competitive sports, being aggressive, etc., are considered attributes of men. So a man who is, or a person who is male, who's not necessarily interested in outdoor sports, who's not necessarily interested in, aggressive activities, may be actually seen as unmanly in certain contexts. So a lot of gender is kind of social, but these are a set of social attributes that are attached to what the associated sex is. So if a person is born female or assigned female at birth, she is expected to be interested, to be domestic, to be interested in child rearing, to be interested in dolls and toys, interested in keeping the family together, interested in preserving the culture and tradition. Lots of attributes come there. And all of these are also a kind of socio-culturally variable. So what may be considered masculine in one culture, like for example, wearing ear studs, may not be considered masculine in another culture. Okay, so there are those kinds of things. There's some cultural variability also. Now, apart from what society deems gender, so when we say male and female, typically we refer to sex. When we say man, woman, masculine, feminine, we are referring to gender. And so apart from these social aspects of gender, there is an individual's inherent feeling of being a boy or a girl, or both or neither. And we go to the American Psychiatric Association, which says a person's deeply felt inherent sense of being a boy, a man, or male a girl, woman, or female, or a gender that may or may not correspond to the person's sex assigned at birth or to the person's primary or secondary sex characteristics. Let's kind of unpack this a little bit. You have an individual who is born with male body parts. The person is assigned male by the doctors who deliver the child. As the child grows up, the child very strongly feels that they are a girl. So the child may want to engage in behaviors that she sees are characteristic of other girls. The child may want to dress up in women's clothes, etc. So all that goes along with the individual's gender identity. So the bottom line of the slide is there is an extrinsic part which WHO defines in the following way for gender. And we have an intrinsic aspect that the American Psychiatric Association defines as a person's deeply felt inherent sense. And an important point is gender identity can develop pretty early in age in children as young as 2 and 3, yeah, or older. For some people, gender identity may develop as they enter adolescence, but if people have a very strong gender identity that is different from their gender and sex, this results in a discomfort which is called medically or in the psychiatric literature as gender dysphoria. So when let's say a child grows up assigned female at birth, is being raised as a girl, but the child really feels that they are a boy. So that child can feel a deep sense of discomfort and distress when that child starts menstruating, developing breasts, etc. And all of this is called gender dysphoria. Okay, so if a person's sex and gender are conforming to their gender identity, as is the case for most of us, such a person is called cisgender. If the person has a gender identity which is different from the gender and sex, that person is called transgender. So unpacking this further, so gender identity, contrary to gender assigned at birth based on biological sex. So typically at birth, it's the external genitals that will lead a doctor to saying that this is a boy or this is a girl. But if the person develops a gender identity which is different from that of a boy or a girl, like a female assigned child develops a gender identity of a boy, or a male assigned child develops the gender identity of a girl, such a person is transgender. And put very simply, a person who is not transgender is cisgender. Okay. Now, within the transgender umbrella are further categories called binary and non-binary transgender. So a person assigned female at birth who identifies very strongly as a boy, a person assigned male at birth who identifies themselves very strongly as a girl. These are both binary transgender people because they have gone from one binary identity to the other binary identity, to man or woman. But there are trans people who don't feel like either. And such people are referred to as non-binary. And it's often abbreviated to the letter NB, the letters NB. Now, again, in traditional Indian society, you have the Hijra or Kinnar community, which in Tamil Nadu we refer to as Tirunangai and Tirunambi, the Tirunangai in particular. And they themselves refer to each other, to themselves as third gender or Moonram Palanam, which is another example of a non-binary identity. Okay. Before gender identity, we spoke about sexual orientation. So I want to emphasize here that the two of them are independent of each other. So a person assigned male at birth who identifies as a woman, so in other words, that person is a transgender woman, should be referred by he, her pronouns. You can't assume that that person is attracted to men. The person may be attracted to men or women or non-binary people or all of the above or none of the above. So there is not a one-to-one correspondence between gender identity and sexual orientation. Now, because trans people are more visible in society, there are a lot of Indian language terms. So Nupi Manbi is a Manipuri term for trans woman. Nupa Manba is a Manipuri term for trans men. Hijra and Kinnar are terms from Hindi and Urdu. Tirunangai and Tirunambi are terms from Tamil. Arvani is also an older Tamil term. And then there are English terms like gender fluid, agender, non-binary, etc. Now, very often when people think of transgender, they think of people who wear saris or other female attire. But that is only one part of the whole transgender umbrella. And those people are usually assigned male at birth, who come to identify as women or third gender. But there's an equally large population of people who are assigned female at birth, who identify as men, but they're not as visible. And there are a lot of social reasons for that, where it's, traditionally a male assigned child who feels different and who faces hostility and violence at home or school can actually run away and join the Hijra community. There is like a support system, but there is no such support system for trans men, that are people who are born assigned female and who identify as men. Also, there are many more social restrictions on them. Their parents treat them as women. They have less economic and social mobility. They're more likely to be forcibly married off by their parents also. But there are trans men as many probably as trans women. Yeah. Okay. Now, I'm going to again stop here and look to see if there are questions so far. Somebody asked about the term transsexualism. Transsexualism is an old medical term which is not used anymore. Traditionally, transsexualism referred to a transgender person who had undergone or desired to undergo what is called a gender affirmation surgery, which used to be formerly called sex reassignment surgery. So a transgender woman who basically goes in for a vaginoplasty, breast construction, breast implants, etc., would be called a transsexual woman. A transsexual man would be somebody who goes in for hysterectomy, oophorectomy, mastectomy, male chest reconstruction, phalloplasty, etc., etc. That is construction of a penis, construction of a masculine appearing chest. But this term is not used outside the medical context. People tend to use the transgender term, and the transgender term is more inclusive. And even if you look at the legal system in India, an individual is recognized as trans and has access to rights regardless of their surgical status or the status of their taking hormone therapy. In 2014, there was an important verdict by the Supreme Court of India called the NALSA verdict, National Legal Services Authority verdict, which basically said that a trans person has the right to identify themselves as male, female, or third gender, and asking them for proof of surgical change or hormonal change is both illegal and immoral. So even now, even if you've not had surgery, you can identify yourself as a transgender person or a man or a woman. So that's why the term transsexualism it's also seen as a very pathologizing term. It treats trans people as somehow ill, and the World Health Organization itself has removed the old term gender identity disorder from ICD. So ICD now has a term gender incongruence. Of course, homosexuality was removed from ICD way back in 1990. So homosexuality and transgender identities are not considered mental disorders anymore. So I'm going to stop here. Regarding transgender people or the transgender community, what are some of the questions you have? Hands up and you can speak. Anyone? Abhijit, do you have your hand up now?
Yes,
Yeah.
so no, I just needed a clarification. You mentioned that the non-binary are people who identify with neither male nor female.
In terms of gender identity, not in terms of
Okay.
biological sex. Yeah.
So the Hijra community is a typical non-binary. Is it the Chakkas whom we call?
Yes. Yes.
Okay.
Though they may not use the term non-binary, they may use the term Tritiya Panthi or third gender or something. Yeah.
Yeah, got it.
Yeah. Somebody called Kashish started talking. Do you want to speak something?
So there was one more recently in the sports. I think in the Olympics, was some sports thing internationally? They banned transgenders from and competing in the women's sports, right? Running, because they would.
They banned transgender women from competing in women's sports using the argument that they have higher endogenous levels of testosterone, which gives them a competitive advantage. This is a bit of a controversial move. There are some pros and some cons to this argument, because even if you look at people who are not transgender, who are quote unquote biologically female, biologically women, there is as much intra-group variation in endogenous testosterone level as there is differences between trans women and cis women. So this is a controversial take, and but right now many sports say that a trans woman can participate in women's sports if she is on spironolactone or some other testosterone inhibiting treatment and has her testosterone levels lower than characteristically male levels. Yeah, but yeah, we can get into that later. Maybe we can look at health-related issues or palliative care-related issues or any basic issues or points of doubt or points that need further clarity. Yeah. Yeah. Sajjan, did you have a question?
Yes, it's kind of continuation to my earlier question is, so now that we have sexuality and
Gender identity.
Identity and orientation, how are they connected? In other words, especially with identity and orientation, how are they both connected?
Which identity, sexual identity or gender identity? Because I mentioned both. Earlier, when I talked about sexual identity, I talked about men attracted to men identifying themselves as gay, women attracted to women identifying themselves as lesbian, people attracted to multiple genders identifying themselves as bisexual or pansexual, etc. Gender identity is identifying yourself as a man or a woman or neither, regardless of what your sex assigned at birth is. And the point I made was that the gender identity and the sexual identity and sexual orientation need not be connected to each other. So you can have a person who's assigned male at birth, who is attracted to women, but who may identify themselves as a transgender lesbian. So the person is a transgender woman attracted to women. So that person would be both transgender as well as lesbian. So you can think of sexual orientation and gender identity as two right axes at orthogonal to each other, at right angles to each other, and one can vary independently of the other.
Okay, actually, it is a bit confusing, and I cannot grasp everything
Okay.
around.
Okay.
But it's okay. We can, yeah, we can go ahead. I think it's something that I'm not able to.
Okay.
Yeah.
Okay,
So,
I'll try. I think it's my fault for not explaining clearly enough. Let me try to do it this way. Who you are attracted to is independent of whether you feel yourself as a man or a woman or both or neither. Okay, so I may feel that I'm a man and my body may also be male, and I may be attracted to women, in which case my sexual identity would be straight or heterosexual. And my gender identity would be cisgender, meaning my gender and my gender identity are both male. Okay, so I'm a male, cis male. I'm not a trans male. I was assigned male at birth. I'm attracted to women. And I identify as a man. But I may be assigned male at birth, but identify as a woman. That does not dictate who I'm going to be attracted to. I may be attracted to women or men or both or neither. Yeah. Okay. Okay.
Sir,
I think.
yeah. Sorry. Go ahead.
No, go ahead, Mr. Gomez. Yeah.
Yeah. I just wanted to ask you to clarify about cisgender. I just put the text there on your chat box.
Okay. Okay, cisgender is the opposite of transgender. So if you are not transgender, you are cisgender. You may have heard of the terms cis and trans in organic chemistry, where cis basically Latin for on the same side and trans means on the opposite side. So if your if you're biologically male, but you identify as a woman, you're transgender. If you're biologically male, but you identify as a man, you are cisgender. If you're biologically female and you identify as a woman, you're a cisgender woman. If you're biologically male, but if you're biologically female and you identify as a man, you're a transgender man. So simply, if your gender identity and your sex, biological sex, if they are concordant, then you're cisgender. If they are discordant, then you're transgender.
Okay, thank you. Thank you.
Yeah.
Sir, one more question I have is regarding WHO. Any particular reason why they have removed the gender identity disorder as a whole? I mean, any reason for that? Or what are the justification they have?
So earlier, so I think it's similar to what they did with homosexuality, because initially everyone operated on the assumption that everybody is cisgender and everybody is heterosexual, and a person who's not heterosexual or who's not cisgender, there's something mentally wrong with them. But then research studies came along. The initial work, the initial psychiatric and psychological studies with these communities were all studies that were based on a skewed sample of people who are actually seeking psychiatric services for other mental health conditions. You know, they might have had PTSD, they might have schizophrenia, this, that, or the other. So then came some researchers who decided not to take a clinical sample, but take a sample of people from the community who are not visiting psychiatric clinics for treatment. And then they found that statistically, they could not distinguish between homosexual and heterosexual or transgender and cisgender based on any of the psychometric tests or any other tests. So that was one piece of evidence, and more such pieces of evidence have come showing that just like, you know, handedness, right-handedness is dominant, but left-handed is rare, and ambidextrity is maybe more common than left-handedness, but not as common as right-handedness. Just like that, there's variations of sexuality, there's variations of gender identity. And more importantly, people with these different identities are not necessarily having any associated mental disorder. Just being transgender seems to be a variation in nature, just like being homosexual, heterosexual, asexual is. Because society has a particular worldview, these are pathologized, just like being left-handed was pathologized and criminalized some 200 years ago. And people were, subjected to all kinds of, attempted cures to make them right-handed. But with more and more knowledge that this is just a variation in nature, the thinking of these as psychopathologies has given way to a more nuanced understanding.
Sir, just a question. Is it this variation that you're talking about, is it linked to any genetic kind of an variance in the person's makeup of the human body, or is it something that happens along the way? And how do we kind of understand this part of nature? How do we understand?
Like with most phenotypes, there is a combination of genetic and environmental and developmental influences. So there have been some studies that have shown a region of the X chromosome, which is enriched in some families. If you do a pedigree analysis, a population genetics analysis, and we find many more people who are gay men, with the pattern of transmission, the pattern of gayness or homosexuality suggests an X-linked recessive trait. And this is a study done in the US with several hundred subjects. But there have been similar studies in other countries that have not been able to replicate it. There are some studies with transgender women that show a higher than expected exposure to estrogen in utero. But there are other studies that have failed to confirm this. So it's possibly some combination of genetic, embryological, and environmental influence. But the exact It's certainly not a single gene, single trait kind of inheritance. It could be polygenic, but also environmentally malleable. We call it reaction norm in population genetics. So there could be a cluster of factors. One thing is very clear, that purely nurture, being exposed to a particular environment, does not change and cannot change a person's sexual orientation or gender identity. Even there's a very common stereotype that being abused as a child makes a person gay or lesbian, and there's enough evidence contradicting that. In fact, a very prevalent theory was that girls who get sexually abused become lesbian. But if that theory were true, 75% of women in India would be lesbian, but that's not the case. So there's enough data that child abuse or sexual abuse or other influence does not change a person's sexual orientation. But I also want to make clear here that there is a difference between sexual orientation and sexual behavior. If a person is a man, is in an all-male setting, like an army camp or a college hostel or something like that, where there are no individuals of the other gender around, there may be a certain amount of sexual behavior that is towards members of the same sex, but it is not accompanied by the same kind of emotional orientation that is characteristic of people who are gay or bisexual. So sexual behavior can exist independently of sexual orientation. Okay, so in certain circumstances, like a prison or a jail or a hostel, you might have same-sex behavior, but that does not translate into sexual orientation changing. They would after that period of being in an all-male environment, they would just go back to a regular heterosexual existence. And we can't say that that particular environment made them gay. It made them engage in same-sex behavior, but that's not the same as orientation. Okay.
That's very helpful. Thank you.
Yeah, thanks. I'm going to get to another part which is often confused and confusing, which is, okay, let me get to this before I get to that, gender expression. So we all have our ideas of what masculinity and femininity is about. So if you see a male child who is sitting alone in the classroom while the rest of the classmates are out kicking a ball in the field, or that child has a preference for pink clothes or something stereotypically female, such a child would be deemed effeminate or girlish and also be subjected to violence and harassment and teasing. So this is the gender expression of the child, and the gender expression of a child does not necessarily correlate to the gender identity of the individual as an adult. So if you take 100 individuals who are as children effeminate male, only about 20% of them would grow up to identify as transgender. The others may be, cisgender, they may be gay, lesbian, heterosexual, asexual, anywhere. But the point here is that these early experiences of harassment and bullying can render the environment, the learning environment, very unsafe for the child, and also result in a lot of children dropping out of school. So the bottom line here is gender expression is how a person manifests themselves in terms of speech or dress or behavior, which may or may not be associated with a gender identity. A child who's 3 or 4 years old, a female child who wants to cut their hair short, wants to run up, climb trees and play cricket, may not necessarily think of themselves as a transgender man as an adult, but still their gender expression may result in a certain amount of stigmatization from peers and teachers. Okay, and a person whose gender expression does not conform to their gender is called gender non-conforming. So an effeminate or feminine acting boy is called a gender non-conforming child. Similarly, a butch or masculine acting female child is also referred to as a gender non-conforming child. So a gender non-conforming child may, as an adult, identify as heterosexual, lesbian, gay, bisexual, or transgender. One cannot necessarily predict adult gender identity and adult sexual orientation from childhood gender non-conformity. However, many in the LGBT communities report being GNC as children. Okay, gender non-conformity is not an identity. If there is time, maybe I'll play a video, but I think we may not have time for that. I'll go to the other slides and see if there's time. Okay, now I earlier talked about gender dysphoria. So if somebody is assigned male at birth based on male body parts and they're uncomfortable with that, they are gender dysphoric. Not all gender non-conforming children are gender dysphoric, but some of them are. The term gender dysphoria is what's used in the DSM, Diagnostic and Statistical Manual of the American Psychiatric Association, which is used worldwide. The World Health Organization uses the term gender incongruence with ICD-11. Now, if a person is gender dysphoric and actually wants to undergo surgery, so one myth here is that all trans people want to go undergo surgery. That's not true. Many of them do, but not all. But if a person wants to undergo surgery, they have to first see a psychiatrist who will rule out that the gender dysphoria results from an unrelated psychiatric morbidity like schizophrenia or delusional disorder, because those can also result in a person manifesting a gender which makes them other people think that they're transgender. So in other words, a person who's schizophrenic or has a delusion that they are the Queen of England or that they are Indira Gandhi, right? So they may have completely divorced from reality, and identifying themselves as a different gender may be a part of that psychiatric symptom. So the psychiatrist has to distinguish between a person who has a psychiatric condition versus a person who's gender dysphoric and doesn't have any psychiatric condition. Okay, so, and that diagnosis is required because the surgeries are irreversible and you don't want a person to be wrongly diagnosed. But legally, to be identified as transgender, you do not need to have surgery or hormone therapy or anything like that. Okay, sorry. Okay, now I'm getting to sex, which I should have got to in the beginning. But I put it to the last for a particular reason. When we talk about biological sex, we think about external and internal body parts. We think about karyotype, where XY is associated with male and XX with female. We think about the relative proportion of androgens versus estrogens, of which testosterone and estradiol are examples. We also think about the sex determination system, where individuals are diploid. The sperm and the eggs have one single X chromosome or one single Y chromosome, which fuse to give you an XX girl child or an XY boy child. So this is assuming this kind of makeup, that there is a one-on-one correspondence between all of these. So an individual with these body parts, with a penis and a prostate and testes, will necessarily have XY chromosomal makeup, will necessarily have more testosterone than estrogens. But this neat lineup is not always the case. You may have an individual with female body parts, but who actually has XY karyotype, but whose body does not respond to the masculinizing effects of testosterone. And the person is born with a female phenotype. Here's an example. So there is a condition called androgen insensitivity syndrome. So depending on how much the body responds to testosterone during development, you can have a child with XY chromosomes born with a completely female genital system to a completely male genital system to any number of intermediate genital systems. And this is what some of these look like. So all of these are examples of what we call intersex, which is the I in LGBTQIA. So this is an example of an intersex condition which is visible at birth. But there could be a condition where, you know, a child is born with a completely female phenotype, and the doctors say this is a girl, and the parents raise the child as a girl. But at puberty, the child does not menstruate, does not develop breasts. And then the parents get worried and send the child to a doctor, and the doctor does a karyotyping and find that the child is XY with androgen insensitivity syndrome. There are also sex chromosome related intersex conditions like XXY, XO, etc. So there's what's important here is that this is actually about body, external body parts or chromosomes or hormones, and the prevalence of intersex conditions was thought to be very, very, very small. But based on more and more data from systematic reviews coming up, the prevalence is almost 1 in 100 individuals is what we are seeing these days. So you may have read a lot of stories in the news about sports people, like in Pinky Pramanik in West Bengal, Duti Chand in Odisha, Shanti Soundarajan in Tamil Nadu, who were at one point or the other disqualified from sports, from women's sports, because they quote unquote failed a gender test. So most of these people are intersex people who have a female phenotype, but who may have some intersex condition or the other. Okay. But here also what the law says is that if an individual identifies as a particular gender, they should be considered as that gender, and you shouldn't try to impose your own idea of gender on them. Okay. I'm again quickly pausing. Do you have any questions about intersex? A common misconception that people have about the Hijra community is that Hijras are born with intermediate parts, with parts that are intermediate between male and female. But that's not necessarily the case. Intersex is not the same as transgender. Transgender people may not be intersex, but a few trans people may be intersex. But it's not necessary that a transgender person is necessarily somebody with intersex conditions. Yeah. Questions? Abhijit.
So these intersex people, do they have, since they seem to have both the genitalia, then do they have sexual feelings, or they are asexual mostly?
They could be asexual, they could be heterosexual, they could be homosexual, they can be anything.
All right. Okay. Thank you.
Sure. Anyone else?
Sir,
Yeah.
regarding the karyotype of a woman, you said that they may be XY also.
Yeah, yeah. So XY with androgen insensitivity
Can you
syndrome.
explain little indeed?
Yeah. Okay. So if you have a sperm with a Y chromosome fusing with an egg, with an ovum that has an X chromosome, the child is supposed to be developing as a male, correct? And then you have the TDF, the testis determining factor on the X chromosome. You have a series of biochemical pathways where the child develops a phenotype that is male. But if the child has a condition called androgen insensitivity, and which is again a continuous variable, the developing fetus may respond to masculinizing or virilizing effects of testosterone to different degrees. So if the child has very, very mild AIS, the child may develop with an external phenotype that is male or close to male. If the child is completely insensitive to androgen, it's what we call CAIS, complete androgen insensitivity syndrome. The child is born with a phenotype which is female, even though the karyotype is XY. So you can Google or go to a medical textbook and look at CAIS, complete androgen insensitivity syndrome, and PAIS, which is partial androgen sensitivity syndrome, and explain to you, how you can have a female with XY karyotype. Yeah, thanks. Okay, I want to do a quick time check. It's 3:54. Do I have time till 4 or 4:15 or 4:30? Can someone help me?
So you have time up to 4:30.
Okay, great. Okay. So I've talked so far about, the spectrum of sexual orientation, gender identity, gender expression, and intersex conditions. Now I want to talk more about social issues affecting these communities, why we consider them to be marginalized communities, and what implications these have for healthcare. So very often people in our society, when they hear about LGBTQIA, they say, oh, all of this is not found in our culture. We only see it with the effect of Hollywood or the internet, or people being exposed to Western culture. This is actually not the case. There are a lot of examples from our history, from our mythology, even in present day indigenous communities in Manipur that are untouched by or minimally touched by colonialism, both Christian colonialism as well as Hindu colonialism. Transgender children are considered to be a blessing from God and are revered. We have sculptures from Konarak, Khajuraho. You have references in Kama Sutra, etc. To same-sex behavior. You have references to Shiva as Ardhanarishwara, who's half male, half female, which is a bilateral androgyne. So there are a lot of references. But historically, you will find, for example, in Manusmriti, if a person is a Brahmin male and that person has sex with another male, then the person is considered impure and has to have some kind of rituals in order to purify himself. And if a woman has sex with another woman who is not married, then again it's a disgrace, and she will be humiliated and paraded around with a shaven head on a donkey. But there are these kinds of things. But in general, there are also a lot of references, including Hindu texts, mythological texts, if you believe in them, that that people, especially transgender, if you go to the narratives of Brihannala or Shikhandi in the Mahabharata, or in the Ramayana, we have an entire episode of when Rama goes off to the forest. He says all the people of that town who follow him, are very grief-stricken, and he says, "Oh, all men and women go back." So there are transgender people there who don't identify as men and women, and they just stay there at the edge of the forest. And when he comes back from his exile, he asks, "What are you doing there?" And they tell him, "Oh, you asked men and women to go away, but we are not men and women, so we waited here for you." And then they got blessed. So there are all kinds of these narratives. Arjuna living as Brihannala, working as a dance teacher, all of that. So the point is that this is nothing new to our culture, but our culture, like most other culture, emphasizes man, woman getting married, having children. And in fact, if you go to rural areas, many rural areas, people may know that somebody is homosexual, but as long as they are married and have kids, often people turn a blind eye to what else is happening, right? There are also people who, especially in the medical community, who says all of this is unnatural. But again, if you take nature literally as biological diversity, there are over 450 species where behavioral biologists have documented homosexual behavior and bisexual behavior. And this is not a one-time thing where a male mounts another male during a rutting season. You actually have male-male couples and female-female couples raising eggs, raising young across, chimpanzees and swans and dolphins and penguins, etc. So the argument that it's not found in nature is also an argument that's very easily demolished. Then what is the problem? Problem is really socially, we enforce heterosexism. We say that as a boy, you should act in a manly manner, you should only be attracted to women, and vice versa. And you should get married and you should have children. And if you have male children, so much the better. And if a child is gender non-conforming, like a feminine male child or a masculine female child, that child is subjected to bullying and other abuse by peers, these gender non-conforming, which leads to issues like suicidality. Also in our Indian tradition, if you will, and in fact, just recently, the National Medical Commission has outlawed it. There is a practice called conversion therapy where doctors will be approached by parents saying, "There's something wrong with my child. He's a boy, but he's acting like a girl. Please change my child." And psychiatrists and sometimes pediatricians will try everything from cognitive behavior therapy to electroshock therapy to try and change a child's orientation or gender identity. And all of this is unethical. It's unscientific because it doesn't work. And now it is also illegal. Both the Kerala High Court and Madras High Court have banned this. And recently the National Medical Commission has also said that this is unprofessional and behavior, and people who practice this, whether they're psychiatrists or clinical psychologists, etc., risk losing their license with the Medical Council or Rehabilitation Council of India. Okay, here's a summary of mental health issues associated with being of a non-mainstream sexual orientation, SO, gender identity, GI, or expression, E, or sex characteristics, SC. So SOGIESC is an kind of a term coined by the United Nations system, because every country has its own terminology for gay, lesbian, bisexual, transgender. So the common terminology is people of non-mainstream, SOGIESC, sexual orientation, gender identity, expression, or sex characteristics. So you have discrimination against homosexual people, bisexual people, and transgender people, which is called homophobia, biphobia, and transphobia, respectively. Such people are stigmatized, discriminated against. For some people, it's very difficult to come out and declare their orientation. 2 days ago, I spent about 4 hours in the police station and on the streets with a particular case where a young girl from Madurai, 24-year-old girl, her parents refused to accept that she was lesbian, that she was attracted to women. They forcibly tried to admit her to a psychiatric institution, saying that she was insane. And even though she was legally an adult, they refused to let her go where she wanted. They wanted control of her, and they wanted to sedate her and admit her in an inpatient facility. So these kinds of things make it very difficult for people, especially outside of urban and outside of maybe middle and upper class, to come out, with the possible exception of transgender women, who by their very nature are very visible and may even get kicked out of the house at a very early age. So all of these experiences of hostility and social isolation, exclusion, and rejection leads to various mental health outcomes like low self-esteem, depression, anxiety, including social anxiety, eating disorders, drug and other substance use, self-harm, suicidality, and other issues. Okay, there's data from cisgender, gay, lesbian, bisexual people. The cisgender is a person who's not transgender. So both among gay, bisexual adolescent boys and lesbian, bisexual adolescent girls. So this is thoughts of suicide and attempted suicide. It's much greater if the adolescent is gay, lesbian, or bisexual than if the adolescent is heterosexual. If you have transgender people, the data set of about 6,400 people, you have a suicidal, sorry, 1 second, 47% having admitted suicide, attempted suicide, 57% facing family rejection, 19% refused mental care, homelessness, inability to change their gender or their identities, etc. This is from the United States. So the data from India, we do not have quantitative data, but arguably all of these issues are very much prevalent. Okay, now in the context of education, for example, I told you that gender non-conforming children are subjected to a lot of violence. I use the word gender non-conforming, GNC, because a lot of young children may not have deciphered what their identity is. They may not be old enough to say I'm gay or I'm transgender, but they may still be gender non-conforming and face verbal, physical, emotional, and sexual violence because of it, leading to isolation, lack of belonging, anxiety and depression, suicidal ideation, with educational outcomes like fall in grades, loss of educational aspiration, increased absenteeism, and dropout. So many of you ask, why are transgender people begging on the streets or selling their bodies for sex? Why can't they get regular jobs like everybody else? The answer for that is right here. Many of them have been gender non-conforming children, bullied, dropped out by class 5 or even earlier, don't have an educational certificate, let alone a college degree, are unable to get a job. Even if they do get a job, they face a lot of hostility. So there's no environment where they can function and thrive other than begging on the streets or doing sex work. So again, I'm talking particularly about trans women, but to different degrees, these issues persist for all LGBTIQ people. Okay, what does the law say? Since 2018, it is no longer a crime to be in a same-sex relationship. India, like other British colonies, inherited a law called the sodomy law, which was section 377 of the Indian Penal Code, that said, regardless of whether an individual is in a consenting relationship or a non-consenting relationship, if it does not involve a penis and vagina, it's a crime. So in 2018, the Supreme Court changed that and said that as long as you are adults and you are in a consensual relationship, it's not a crime. In addition, since 2014, the NALSA judgment, transgender people have specific protections under the law. Also, there are scientific statements against conversion therapy, okay, saying that any person attempting to change the sexual orientation from homosexual to heterosexual or the gender identity from transgender to cisgender should not be doing it. One of the champions of abolishing conversion therapy is Dr. K.S. Jacob, who was the head of psychiatry at CMC Vellore. And he has written a lot of editorials about that. Madras High Court banned it in 2021. Kerala High Court also banned it then, later that same year. And now National Medical Commission has banned it. Okay, now I'm going to quickly pivot to palliative care. So what are some barriers to accessing palliative care for LGBTIQA communities? First of all, if we look at the different arms of palliative care, you may have institutional care, you may have people coming over, you may also have caregivers from the biological family who are part of the palliative care system. However, a lot of LGBTIQA people who are out or open about their identities or who are discovered to be LGBTIQA are forced out of house or are estranged from their families. It's not very pleasant to be part of a family and where at every family function, every relative is asking, when is your child getting married? Or a parent saying, I want grandchildren, etc. So many in the community are estranged from their families. Also, relationships between two men or two women, or a trans person and another trans person, or a trans person and a cis person are not recognized by law. Also, many LGBTIQ people have a history of being treated with hostility or indifference in healthcare settings. I gave you the starting example of a gynecologist asking a woman, are you married? As a way of eliciting her sexual history information. So people who are lesbian or bisexual may not be even comfortable disclosing their orientation and identity and behavior in such a setting. And many people hesitate to go and see a doctor, even for a simple thing like a mammogram or a pap smear or any other thing, because they are afraid they will be stigmatized if they declare their identity. Also, within the palliative care community, we just assume that everybody is heterosexual, and we are not that aware of the LGBTIQA community. So that also contributes to a barrier in accessing palliative care for those who can actually afford it and access it. So I'm going to leave you with some thoughts on what we can do as palliative care providers to make our care more accessible to the LGBTIQA communities. So while doing intake, when meeting a potential client as a caregiver for the first time, create a circumstance where you can have that person disclose their SOGIESC, their sexual orientation or gender identity or sex characteristics in a safe and comfortable place. They may need the privacy, they may not be open even to other people in the biological family, but you need to create that space. You ask them, if they appear to be unmarried, you ask them, do they have a special someone, or did they have a special someone? Ask them the gender of that person. Very important, do not assume what their orientation or identity is based on their behavior or their appearances, because those can be misleading. So if you do these things, and again, it's challenging to do it in the local language, to ask, are you attracted to men or women or both, or have you been in a relationship with men or women or both? But with practice, you can create an environment where they feel safe disclosing this. And this is important for further care that you give for maybe, overall, if you do these things, you can, contribute towards greater comfort level, satisfaction rates, etc. And all of this is data from studies that have happened in North America, but maybe some of these are adaptable to the Indian context. So one more thing here is, understand the lived experiences of the community through their experiences of multiple external and internal stressors, implicit and explicit bias, oppressive and discriminatory encounters, and destructive healthcare systems. What we mean about this is that if you are a minority, in this case, a minority with respect to sexual orientation or gender identity, it could also be a minority with respect to caste or religion, you can face what is called, again, in the psychology literature, as minority stress. And if you face multiple stressors, like you're both a transgender person and a Muslim, or a transgender person and a person with disability, all those minority stresses can compound with that person. People may have faced implicit bias as well as explicit bias. Explicit bias is, oh, you transgender people don't go in this clinic, this is not for you. Implicit bias is that, okay, this hospital only has male ward and female ward, and you don't know where to go to get admitted, things like that. And many of these are there in the healthcare system also. So you have to understand before you can provide appropriate palliative care, understand what people have gone through, what some of these past experiences which may have been traumatic are, and accordingly tailor your care. And again, inquire about existence of families of choice. Sorry, there's a typo there. Existence of families of choice. So it's not necessarily father, mother, husband, wife, brother, sister. There may be other people who are non-biological relatives, but who belong to the same community and who have come to be part of their support system. There could be relationship partners who are not recognized by law because India does not recognize them. But if you want to be sensitive, you ask about these questions, and you can also explore how they can be included in the palliative care, including things like advanced care planning. Okay, now if you have a transgender person, you might face a dilemma. The transgender person may have had some surgeries. The transgender person may not have had some surgeries. For example, for a trans man, it's a very common surgery to have the breast removed, and also relatively common to have the uterus and ovaries removed. But it's not very common to have a penis reconstructed because that surgery is very complex, and not many doctors in India have the capacity, the skills for that. So if you are going to do physical examination, you take permission from the patient for the examination, and you allow the patient to take the lead based on their comfort level. So they may not refer to, a trans man may not refer to their vagina as a vagina, okay, etc., etc. So you ask them, can I make an examination? What do you call this part, etc. And you just do it very consensually. You build trust. If you do not need to examine a particular body part, you don't have to. Like, for example, there are a lot of unethical practices where doctor just out of curiosity and for no real valid medical reason want to see what's inside someone's pants. So you have to do away with all of that and be respectful while examining the client. Okay, so I am stopping here. There is additional reading that I can share and a PowerPoint that I can share. We have a good 18 minutes for Q&A. Thank you.
That you mentioned about a video. Is there time to show that one?
Oh, yes. Give me a second. I'm just going to look for that video. Just give me 1 second. Yeah.
Meanwhile, if anybody has any questions, please do feel free to put it up in the chat box.
Okay, I've got it. I'm going to display that. Do you see my screen?
Yes, it's visible, sir.
Okay.
We went to the preschool for open house, and all the kids had their self-portraits up. And Rylan made a vest, huh?
A vest, a
And
tie.
and his short hair before he even had short hair, huh? Remember that? You made this when you had long hair, but you knew what you
Just checking if the audio of the YouTube is audible.
Yes, sir, it is. It is.
Okay.
looked like inside your head, huh?
You have chip on your face, dude.
I made it short hair.
Mm-hmm. And that was...
Yeah. I'm going to be sharing the link. It's going on for another 8 minutes, which I thought we could use for Q&A. but it just goes on to describe how the parents in this particular case supported their transgender son, who was again assigned female at birth, through social transition, which does not involve any surgery, but just hairstyle and clothing and referring to him as a boy. And perhaps sometime in the future, after the child is older than 18, they may consider surgery. So this is just an example to illustrate that a gender non-conforming child, who also in this case has acute gender dysphoria, if supported by the parents, can grow up happy and healthy and productive. And if you look in the Indian context, on one hand, you see the trans people who are on the streets begging. You also have examples of trans people who had family support right from an early age, and they have gone on to be, there's anesthesiologists, there's social workers, there are people who in the government service, in the public service, there are people who are teachers, etc., etc. There's a professor at Ashoka University who's a transgender man. So I think family support is very much critical for transgender and by extension all LGBTIQ people. So I'll leave you with that thought and come back to questions if there are any. If you just want to unmute yourself and ask your question or just reflect, we are in the last 5-6 minutes. So if you just want to give some feedback on what will help you in the future, if you want to learn more about this, or what kind of hands-on experience would help you if you were to take this forward. Yes, Sajjan George, please go ahead.
Just want to check, in the last, let's say, 100 years or so, do we have any kind of data that shows the number of people who have identified themselves, or I mean, is there a trend in terms of how this has, grown? Because we do see these things growing. So do you think, is there any relationship in that in terms of what the society and acceptance it's